Great. Okay, let's begin. 这上面是吧？啊，我们先要不是，先要那个 get Professor Get, you begin.
Am I about to begin? Good afternoon, good evening, good morning, everywhere on the planet. It is my privilege to introduce the speakers to the IAU webinar on ESWL. So I will start with the first speaker, which is Ben Chu.
Recording in progress.
Who doesn't really need an introduction probably because everybody knows Ben Chu. He is the Director of Clinical Research at the Stone Center of Vancouver General Hospital and an Associate Professor of Urology at the University of British Columbia in Vancouver, Canada. He is also the Chair of Research for the Endourological Society, and when he goes to sleep at night, he dreams about stones, so he knows everything about stones. The next speaker comes from Czechia, Czech Republic, and that is Professor Alice Petric, who is a urologist at First Medical Faculty of the Charles University. He is a member of the Urolithiasis Fellow of the European Urological Association of the Guidelines Office, and he is also the Vice President of the European Board of Urology. He is very familiar with all the guidelines, both from EAU, AUA, and VICE, and he will introduce us to these guidelines, which is, I think, very interesting. Dr. Rajeev is a urologist from Bangalore. He is an endourologist with a very special interest in ESWL. He has operated various Lithotripters since 1999, so he has a huge experience in treating kidney stones with ESWL, but also with percutaneous nephrolithotomy and retrograde intravenous surgery. Professor Sarika also really doesn't need an introduction. He is a chairman of the IAU section of Urolithiasis, ULIS, and he is a co-chairman of this organization, the IAU. He is also very involved in stone treatments in general, and I know that he is very much interested in stone treatments in children. And the final speaker is from China, Professor Zhu. He is a committee member of the Urolithiasis group of CUA, the Chinese Urological Association, and he is active in the second affiliated hospital of Zhengzhou University. So I think we will have an interesting evening and hope to learn a lot about ESWL and hope to ask interesting questions to the speakers and get a lot of information on stone treatment and ESWL in particular. And now I would like to introduce Professor Ye, who will do the opening remarks.
Dear friends and colleagues, thank you to each and every one of you for joining us today. On behalf of the Board of the Directors, as Chairman of the IAU, I would like to warmly welcome all of you to the third IAU webinar on SWL. It's our great honor to have you as our guest. Whether you have been with us for a long time or those who are new to the IAU community. Before we get started, I would like to also express my sincere appreciation to all of you. In this webinar, we will discuss the latest scientific developments and clinical applications on SWL. Today, we are proud to have invited estimate experts in the field of the SWL, including Professor Kamil Srika from the Tokyo, Professor Greater Tiny from the Beijing, Professor Bin Cho from the Canada, Professor Alice Patrick from the Czech Republic, Professor Rajeev from the India, Professor Guohua Zun and Professor Chang Baoxu from China, with participation of the experts worldwide. I believe the webinar will provide an excellent platform to show SWL experience and practice from the urologists around the world. I would like to conclude my speech by encouraging urologists to participate in the discussion session for the next 2 hours. I wish everyone a successful and fruitful webinar. Again, thank you all for joining us today. With a round of the applause, let's welcome Professor Bin Chu from the Canada.
Great, thank you. If we can just stop sharing that, then I can share my screen.
Dear friends and colleagues, thank you to each and everyone.
Thank you very much for this honor to be here and for the invitation. It's a real pleasure. So thank you very much. I wish we could attend in person. The last IAU we had in China was terrific. I really enjoyed it. So, and Dr. Tai, thank you so much for that very kind introduction. And it's a real honor to be introduced by you, who needs no introduction. So I am here to talk about shockwave lithotripsy and what has changed in the last 2 decades. I do work for some companies, and I think we all know that shockwave lithotripsy, which initially started with the Dornier HM3, which Dr. Tai knows very well, has changed and evolved. And in some aspects, the technology, actually, the stone-free rates have never been as good as they were with the HM3. So it's an interesting technology in that sense. I want to start with a case. This is a case of a stone in the proximal right ureter who underwent shockwave lithotripsy, and afterwards the x-ray, this is the pre-shockwave lithotripsy, this is the post, there was no difference at all. So very similar. Patient was still in pain, and there was a good study from Canada, from John Honey and Ken Pace, showing that I think we all know what the predictors of stone-free rate are in terms of location, having a lower BMI, and not being in the lower pole. But they followed up 1,500 ureteral stones at 2 weeks and 3 months with an x-ray, and they looked at how many treatments they gave patients. And the initial treatment provided a stone-free rate of about 68%. If you treat it again, it went up from 68%, up 8% to 76%. And then if you treat it again, it only went from 76 to 77. And then if you treated 3 times or more, you only got an increase of success of 1%. So the bottom line for this is that if you continue to treat the same stone with shockwave lithotripsy, results are not very good. In fact, if you fail to or have a very bad response to the initial shockwave lithotripsy, you should probably not do more lithotripsy on that patient, particularly if it's a large distal stone. Now, what about stones in the distal ureter? We all know that ureteroscopy has become a very commonplace, and we've all become very good at ureteroscopy. However, when you talk to patients, we all know this is more invasive, it's a little more painful, and a lot of patients don't want to undergo this, although it's a lot more fun for the urologist. The AUA guidelines say that you should do more ureteroscopy rather than shockwave lithotripsy on distal ureteral stones. However, you should let them know that the complication rate for ureteroscopy is higher than it is for shockwave lithotripsy. And they also quote that there is a higher success rate as well, too, with ureteroscopy. We did a study and looked back at our patients at our center. We do about 2,400 shockwaves a year. And what we found was that for distal ureteral stones, our stone-free rate was about 78.8%. And then if they had 2 shockwaves, it was about 87.5% success. So we actually still had excellent success, about almost 78% with 1 shockwave and about 90% with more than 1 shockwave. Only 12.5% of our patients required a ureteroscopy after shockwave lithotripsy. So we found that shockwave lithotripsy was still very effective for performing treatment for distal ureteral stones. So despite what the AUA guidelines say, we think this is actually very effective, and we offer it to our patients all the time. Now I'm here to talk about advancements and other things that we can add on to help our patients either undergo better stone-free rate or to make shockwave lithotripsy a better experience. They found that if you played music for the patient in some headphones for them, that it reduced their anxiety. Their pain was still the same. You could also stimulate electrical nerve stimulation to see if that would help, because that's been shown in other procedures to help reduce pain. Again, this helped reduce anxiety, but not pain. How about, and this is a study from China, how about if you give them diuretics, so hydrochlorothiazide, during the shockwave lithotripsy? And this actually was shown to be quite helpful. More successful stone passage with diuretics, about 1.73 times more, and at a higher stone fragmentation rate. This is probably because with the more fluid stone interface that you have, the more effective the shockwaves are. Remember, the shockwaves need fluid around it in order to get the acoustic bubble in order to achieve fragmentation. Now, how about energy ramping? This has been shown to be a very interesting, and I think we do use this, and I think a really good idea in order to try and reduce the amount of renal hematomas, and they've shown that lower levels of urinary biomarkers. So what this means is that near the beginning of the procedure, you should have very low energy and low power. What this will do is it will cause the kidney to go into vasoconstriction. So if the blood vessels then become very tight, it has a less chance of basically rupturing and causing a hematoma. What about physical therapy? This is basically turning the patient upside down, causing vibration and combinations, and this is actually Dr. Zhang's work, which is excellent, and this shows that this actually also helped after stone-free rate after lithotripsy as well too. So yeah, I must admit, we do not do this routinely after every patient, but I think that we should, because when they're in the recovery room, for instance, and other things, I think if we had these things, I think it would be very helpful. So it'd be interesting to hear from Dr. Zhang afterwards how he implements this into his practice. And this found basically in all studies here from this meta-analysis that physiotherapy, mechanical percussion, and holding them upside down really did help with the stone-free rate. And here's an example of how you would do it, where you would put the patient so that the kidney is higher than the shoulder, and that way you can get stones out of the lower pole. This is the vibration machine that would help. Now, this is in the hospital with a special therapist. Can you do it at home? yes, you can do it at home. And doing it at home would involve being on the stairwell, putting pillows down, and putting something to maintain the kidney higher than your head, and basically rolling back and forth a little bit. But you have to be careful, obviously, with older patients that they don't get hurt here. This is a company from China, and this is also a special table specifically designed for physical vibration. And I think this is a really interesting idea where the patient is strapped in and it rolls from side to side. It's almost like a bit of a roller coaster. And from the company's data, they found that the experimental group with the mechanical percussion actually had a higher stone-free rate. Now, what about trying to reduce the actual procedure itself? So EMLA, or EMLA, is a mixture of local anesthetics for pain reduction during shockwave lithotripsy. And again, another excellent meta-analysis and review from China. And what they found was that EMLA cream applied to the back actually reduced the pain from shockwave lithotripsy during that time. They said it was limited, and although it did help, it wasn't enough to reduce the need for analgesia during the procedure. So you still needed to give the patients some analgesic, but it was still helpful. So something to keep in mind. I think anything to make the patient's experience during ESWL better is a good idea. So what are we looking at next? And I think, honestly, this is why I was invited to give this talk, because I'm one of the medical directors for Sonomotion, and also performing one of their first-in-human clinical trials here in Vancouver. So this is an ultrasound machine that can do two things. One of them is stone clear, where you can move stones. And then the other one, you can actually change the frequency of the sound waves and actually break stones. So first of all, I'd like to show how a stone can be moved, for instance, from a obstructing UPJ to a lower pole. And what you see here is in a real patient doing ureteroscopy, they then applied the energy, and you actually see the stone move out of the lower pole. So perhaps stones can be repositioned out of the UPJ or out of the UVJ, out of the ureterovesical junction, into a non-obstructing area. They did a clinical prototype, and this is from the University of Washington, and they found that they could move stones from a lower pole calyx into the renal pelvis, and also even into the ureteropelvic junction. And so far they found they could move about a 6 or 7 millimeter stone without any problems at all. So then what they did was they changed the frequency. And we all know, I think, that the HM3, the Dornier HM3 lithotripter, was very successful because it had a very low peak pressure of about 40 megapascals. And when you have a very low peak pressure, I think this allows the stone to break up a little bit better, also because it's so wide. And today's lithotripters have very high peak pressures that are very narrow focused. So compared to this 40 and 100 megapascals, this new technology has a pressure of 4 to 7 megapascals, so much less painful. They do it around 170 kilohertz. And I can tell you so far, we've actually been able to do it with no anesthesia. The patient feels a little bit of buzzing in their back. So with this at 170 kilohertz, and they found different frequencies, 255 or 800 kilohertz. Basically, they found that you could change the stone fragments and the sizes quite well. And now we operate at about 800 kilohertz. Essentially, this is very similar to when an opera singer sings at a resonant frequency and the glass shatters. This is the exact same kind of thing that we're doing with this, because at this frequency, the stones fragment into little pieces, just like this opera singer breaks the glass. This is a time-lapse video of what what it looks like. So we already know there are about 1/10 the focal pressure of shockwave lithotripsy. We're in a special water bath, and it's moving to simulate respiration. And this is only after about 2 minutes. And then afterwards, you'll see that after about 12 to 20 minutes, this will basically be reduced to rubble. And although they thought there would be the potential for no anesthesia, we've actually been using it with no anesthesia at all, like nothing, not even acetaminophen or anything like that. And the patients tolerate it extremely well. The one thing we found that is very interesting is when we hold the ultrasound probe on the stone, the patient, because they're awake, can also look at the screen. And when the stone is in the crosshairs, when we get our best fragmentation. And we had probably about our third or fourth patient say, "Why don't I hold my breath during this time?" And when she held her breath, the stone stayed there more. She could hold her breath for a long time, and then she would take a breath, and then we would go ahead and stop for 20 seconds and then start up again. Again, there's no radiation, and you could do this really anywhere, perhaps in your office, in the emergency room, or even in the clinic as well, too. So we've completed the pivotal trial. We're undergoing first-in-human trials now in Canada, as well as University of California, University of Washington, Cleveland Clinic, and in Baltimore as well, too. And this has been a bit delayed because of COVID, but they thought they would be launching it commercially in the second half of 2021. Probably will be delayed a little bit to maybe beginning of 2022, but I can tell you right now it's going very well. So in conclusion, I've showed that there are some good mechanisms to improve our shockwave lithotripsy that we currently have. The new technology that I'm very excited about is this new breakwave lithotripsy that can be done with no anesthesia and seems to be very effective. And really, I think ESWL is still very relevant and very cost-effective, despite improvements in flexible ureteroscopy and PCNL as well, too. So, with that, thank you very much.
Professor Benchus.
Oh, Dr. Zhang, you're on. You're on mute.
Yeah, many thanks for your nice presentation. Actually,
Goha, you're on mute.
Okay. Now it's okay. Now it's okay.
Yeah, now we can hear you.
Okay. Professor Benchu, many thanks for your very nice, very excellent presentation. Because limited time, one question for you. Actually, shockwave is good option for stone disease, but in our department, number of shockwave cases decrease daily and daily. Because 5 years ago, maybe in our department, each year more than 1,000 stone disease patients for shockwave, but for this year, over 2020, is only 400 cases for shockwave. Why? I don't know. Maybe endourology is encouraged.
SMP.
What about in your country? Is the same or stable?
I think it's been very stable here in Canada, and I know my friends in Brazil, because we are doing a shockwave lithotripsy consortium research area. I think it stayed the same because we have very limited access to the operating room. I think that's one of the biggest keys here, is that we will try a lot of shockwave first, and our success rate is still very good, but it hasn't gone down here. And we still get referrals from other hospitals around here because we have the only lithotripter in the city. Actually, that's not true, one of 2 lithotripters, but ours runs every day. And we still get the referrals from other hospitals for their patients to come, and it's still very high.
Yeah, that's true. Actually, in India, shockwave is really less low. Professor, yes? 我们移到下个 OK
Yeah.
And we next
Thank you.
Speak. Okay, thank you.
I would have one question for Ben still about
Okay.
And you say that burst wave will be commercially available probably in 2022. What will be the relative position of burst wave in relation to SWR? Will it be complementary, or will it be a big competitor, or are there special indications that are more suited for burst wave?
I think we need more data, you know, in terms of the stone sizes. We know that Shockwave has good publications up to 2 centimeters, although I think that's decreasing now with the IAU guidelines, maybe down to 15 millimeters. I don't know where that's going to be positioned yet for burst wave in terms of the sizes, because we have not gone above 8 millimeters or so. So that's one thing, is the size, and also the location. In the same places where you cannot see stones with ultrasound, it's the same places where it is not effective. So mid-ureter, not very. You can't do it. If it's in the ureter, in the bony pelvis, you can't do it either. So it remains to be seen. I think it may replace Shockwave depending on where the location is, but it's not going to completely replace it.
Okay, thank you.
Thank you.
Okay, I move to the second speaker. I will invite Alice, Professor Alice, talk about shockwave management of urinary stone. What do the guidelines indicated in the 2021? Please, Alice, Professor.
Good afternoon. So thank you very much for invitation. It's a great pleasure. And I want to speak about the guidelines and shockwave lithotripsy. So the treatment of urinary stone is one of the great changes in the last 40 years. And we went from the old ancient surgery to minimal invasive procedures, practically with no use anesthesia, and very good for the patients. What methods are used in the treatment of urinary stone? At this moment, there are the shockwave lithotripsy, endoscopic method, ureteroscopy, and PNL. And the important is the invasiveness. And the shockwave lithotripsy is still the less invasive procedure, and it's one of the most important things. Do we need guidelines? I think that I have to
Professor,
say that definitely.
sorry, Professor Alice, share your slides. Share your slides. I
shared it.
You might be sharing the incorrect screen if you have 2 monitors, perhaps.
Incorrect. So.
Yeah, we're just seeing your desktop with a very nice golf course. There we go. There we go.
It's okay.
Perfect. Thank you.
Okay.
Sorry. Sorry for mistake. Sorry for my mistake. So just repeat, and we will go just for this. Why? Because the guidelines are evidence-based, approved for the management of the stone disease. And what about the European one? They are based on a work of panel of experts. All is done under evidence-based medicine principles. And what is important, it's done annually search of papers which have a level of evidence 1-to-1, and all have to be evaluated. And if it's correlated, it's necessary to include them. They will perform some PICOs, I will mention on it, especially on the distal ureteric stone, proximal ureteric stones, and each recommendation has to be literature evaluated. And these principles are very good for reaching good results. They are comprehensive and they are covering all topics. And the recommendations are related to diagnostic, therapy, selection method, and even the special cases, as for example, gravidity, children, and renal malformations are. Quite different are the American. They were based on a panel of experts. Search was done between 1985 and 2015, and there were included more than 1900 publications, and there are 45 recommendations. And these recommendations are related to the index patients. Quite different, but very important, are the British guidelines, the NICE one. And there's very good detailed methodology. Very good is there are the non-medical experts included, and there are good description of evidence. And there's a one great difference to the American and European, and they are healthcare system economical evaluation. So it's really covering not only the medicine, but the influence on the health system and spends on the treatment of the stones. So return to the ESWL and the European guidelines. And the success of Shockwave lithotripsy depends on performance of ESWL, the best clinical practice, and some parts of it was mentioned by Professor Cho. Stone, the size of it, location, and composition. And it's one of the very important things. And what about the best clinical practice? At first, the stenting, it doesn't improve stone-free rates, so the patient should not be stented before the procedure. Pacemaker, which was a contraindication on previous time, at this time there's no contraindication for the treatment. Slowing of the shock wave from 90 to 60 shocks per minute, and very good pain control, and it's one of the essential things to limit pace-induced movement and respiration excursions to get good results of the treatment. Coupling, very important, because air pockets in the gel, which covers the cushing, deflects 99% of shock waves. So it's important, careful coupling of the generator. Antibiotic prophylaxis, it's not recommended only in stented patients. Medical therapy after shockwave lithotripsy can reach better results, increasing expulsion stone and increasing stone-free rate. And post-treatment mechanical percussion, it's very good and diuretic, as it was mentioned by Professor Cho. So, what are the contraindications? Still pregnancy. At this time, it's impossible. Uncorrected bleeding disorders, uncontrolled UTI, several skeletal malformations and obesity, which makes problem to target the stone. Arterial aneurysm in the vicinity of the focus is very dangerous, and of course anatomical obstruction distal to the stone. They are still the contraindication. What about the complication? It was very discussed in a last time relation between shockwave lithotripsy, hypertension or diabetes, and it's still unclear, and the published data are contradictory, and there's no evidence supporting the hypothesis that shockwave may cause long-term adverse event. And it's very good to know it because it makes shockwave lithotripsy safe procedure. And what about the complications? They are extremely rare. There are some evidence of the Steinstrasse, and at this time when we are treating smaller stone, practically we can't see Steinstrasse. Still tissue effects, hematomas, but it's still not common and very rare, less than in 1%. So the second topic of the guideline is indication of the treatment, indication treatment of the renal and Eurotarik stone. So at first, let's speak about the treatment of renal stones. The IAU guidelines are indicating shockwave lithotripsy as a first line in a stones less than 1 centimeter, 10 millimeter, and equal for the stones between 10 and 20 millimeters. In the lower pole stone, between 10 and 20 millimeters, it's judged by the presence or non-presence or unfavorable factors for shockwave lithotripsy. So when they are not present, it's possible to do shockwave lithotripsy or endourology. No. So what about factors for shockwave lithotripsy? In the lower pole, it's the stone harness, buellite, cystine, and brushite stone. Unfavorable factors which are steamer infundibule pelvic angel, long and narrow infundibulum of the lower calyx. So let's compare American, European, and a nice guidelines for the stones. And for the stone less than 10 millimeters, first line treatment is nice. And American and European says that it's quite first line and it's equal to the retrograde intrarenal surgery. Be quite known that the decrease of the success for ESWL and ureteroscopy is due to increasing stone size. When we look to the stone between 10 and 20 millimeters, it's still first line for American, European, and British guidelines. When we look to the stone more than 20 millimeters, it's mentioned as a second line option for European guidelines, not related in the American and British. Lower pole stones, they are equal for stones that less than 10 millimeter, indication in American in stone less than 10 millimeter, and so on. And a nice, it's not considering the anatomy of lower pole. And let's have to this paper, which are mentioned in the European guidelines, and they are treatment of the stone between 10 and 20 millimeters, the lower pole. And the value of the anatomy of the lower pole was found only in these two papers. So it's one of the important things. And what is important in the lower pole stones is that even for the retrograde intrarenal surgery, there's an impact of the anatomy. And all of us, you are performing retrograde intrarenal surgery, you know that when you have very long and narrow calyx, it's quite problematic to treat such stone with excellent result. So let's speak now about the Eurotarik stone. It was important that in 2007, the United Guidelines were developed as from European and American guidelines, yeah. But it was published by Glenn Preminger in the Journal of in the European Urology, same as in the Journal of Urology. And now it was slightly changed, and the European guidelines, they are thinking about proximal ureteric stones, the stones which are more than 10 millimeter in diameter. ESWL and ureteroscopy is the same, are equal. Stone less than 10 millimeter, shockwave lithotripsy is the first line option. For distal ureter stone more than 10 centimeter, first ureteroscopy, second shockwave lithotripsy, and stone that less than 10 millimeter, ureteroscopy and shockwave lithotripsy are same as for the indication. Quite nice was the study, the meta-analysis which was done by the Associated Studio European Guidelines, and it was a correlation of distal ureteric stone, upper ureteric stones, and all level 1 and 2 papers were included. And the conclusions are interesting. Well, the ureteroscopy has higher stone-free rate in 4 weeks, but ESWL and shockwave and ureteroscopy, the results are same in the 3 months. Ureteroscopy has better results in retreatment rate and using of auxiliary procedures, and worse result in complication in hospital stay. So the conclusion is ESWL and ureteroscopy, when you compare it in 3 months, you will reach the same results in stone-free rate. When you compare it in a shorter period, ureteroscopy has better results. American guidelines are speaking about this, and it was mentioned by Professor Shaw that the patient should be informed. ASW has lower comorbidity and complication, and ureteroscopy higher stone-free rate, especially that in the distal 2/3 of the ureter, ureteroscopy should be used as a first-line treatment, and it's preferable in hard stone. Very important are the British guidelines, because they recommend from an economical point of view in stones less than 10 millimeters to do 2 sessions of the Shockwave before you are considering any endourological treatment. So I think it's very good to know when you incorporate economical point of view to the treatment. ESWL, it's still very good option for your patient, and it's cheaper for your health system. European guidelines for the children. In children, there are still indication on ESWL, and the indication for shockwave lithotripsy is more pronounced. Why? Because the ureters in the children are wider, they are more flatty, and the children should pass larger fragment even after ESWL than adult. So the conclusions for renal stone, for European and American guidelines, first line treatment to stone less than 10 millimeter equal to the retrograde, and second in first line even in the stone between 10 and 20 millimeters. Nice for stones less than 10 millimeters, first line in the treatment, and no primary indication or retrograde intrarenal surgery. And it's quite great different for the others, and it's one of the message of the British way how to treat the stones. For Urethric stone less than 10 millimeters, same ESWL and ureteroscopy, and of course it's necessary to mention that ESWL is very good accepted by the patient, and in Urethric stone it's just necessary to know when you do the ESWL in 48 hours after first signs of the renal colics, you reach excellent results. American ureteroscopy more pronounced, and of course they are thinking about using a flexible scope in proximal ureteric stone, which is not still so pronounced in Europe. And in a nice first line ESWL for all ureteric stone less than 10 millimeters in all positions of the stone. So thank you very much for your attention.
Thank you, Professor Petric, for this very nice lecture on the guidelines. The NICE guidelines look very interesting, but are very unknown to most people. Probably because they are British, but maybe there should be a way to introduce them to the larger urologic community. What is your opinion about that?
I fully agree with you because the British system is said that it's sometimes quite problematic, and but on the other way, I think that this point of view, the economical, is very good. I had a possibility. Very good thing is that they have a good system of shockwave lithotripsy, and they are great centers, large centers performing good surgery. And I had a possibility to see one in Scotland, and they are very excellent even in the treatment of Eurotarik Stone. It's very good to know it. And I think now will be published one British multicentric study in European urology in which they gave 20% lowering for ESWL compared to ureteroscopy. It's a prospective, and still the ESWL is very good. They reached very good results in the treatment of ureteric stone. It will be published, I think, in a very future in a European urology, and it's possible to see it online now too.
Thank you very much. Is there anyone who wants to weigh in this and give an opinion on the guidelines in general and NICE in particular? Okay. If not, then I think we can go to Dr. Rajeev Bashetti, who will entertain us on ESWL management of the upper and lower tracts with sonographic guidance. Rajeev.
Good evening.
Yeah, I think you're on, yeah.
Yeah. Greetings from Bangalore, India. I'll be sharing my experience about shockwave lithotripsy management of upper tract and lower ureteric stones under sonographic guidance. Fluoroscopy is the most widely used imaging modality during ESWL. The reason for this is it has a short learning curve. It's easy for a technologist to visualize and focus the stone, and it's relatively easy to interpret the fragmentation. It is believed that ultrasound guided ESWL is more difficult and it has a long learning curve, but the fact is it's not, especially for a urologist who already have a background knowledge about ESWL. But all it requires is a small understanding about the focusing techniques. Today in this presentation, I will be discussing about how to focus the stone in the kidney, upper ureter and lower ureter, and how to assess the fragmentation and when to stop the treatment using ultrasound guidance in a simple way. Ultrasound has many advantages over fluoroscopy, especially there is no exposure to harmful ionizing radiation. Radiolucent stones can be easily focused. Most important is the real-time monitoring. Here we can visualize each and every wave hitting the stone. Sometimes the patient can change their position or the stone can change the location. So this can be addressed immediately and refocused. It has its own disadvantages as well. It has a slightly long learning curve and it is difficult to focus the ureteric stones, especially when there is no hydroureter nephrosis. And it is difficult to focus the mid-ureteric stones. Now, when it comes to ultrasound-based lithotripters, there are two types. One is outline, one is inline. In outline, the transducer is fixed down to an isocentric arm, whereas inline, the transducer is fixed inside the shockwave head. There are certain advantages of outline compared to inline, which I will not be discussing here, but in my today's discussion, my reference will be with outline kind of lithotripters. Now, before we proceed with the treatment, it's very important for us to discuss various treatment options available for the patient. Ideal patient is the one who can understand the limitation of ESWL. The patient should be ready to undergo an endoscopic intervention in case ESWL fails. Screening of the QUB region should be done before because the stones can change their location sometimes. And since I do SWL only on adult patients. I prefer either surface anesthesia or no anesthesia. Pre-stenting is not required in all the patients. Now, before we go ahead to understand how to focus the stone, we should have some knowledge about shockwave head position and the isocentric arm movements. That's the shockwave in lateral position, that is 40 degree, and this is the position in 0 degree, that is under the table. Shockwave head movements, that is the lateral movements of the shockwave head, which is required to avoid the bony structures. Isocentric arms moves in and out. This moves the pointer, that is a focus point on the scan, up and down. Probe movements on y-axis. Horizontal movements and the vertical movements. See, all these movements are important to identify a good acoustic window to focus the stone properly. For the kidney stones, the patient position should be always supine and the shockwave head position should be lateral, and sometimes it is required to take the shockwave head under the table, especially in mal-rotated kidneys. Now, most of the kidney stones can be focused through this acoustic window, which lies between the anterior axillary line and mid axillary line. And when we place the ultrasound probe here, we should make sure that the head end marker is always pointed towards the head end of the patient. Otherwise, the whole orientation will be missed. There are certain table movements which are very essential for us to understand. There are two types of movement. One is the vertical movement, other one is horizontal movements or lateral movements. Now, when we place the patient on the ultrasound SW table, these movements, that is the vertical movements, up and down movements, are the first movement what we should do. This will help us to visualize the stone on the ultrasound monitor. Once we visualize the stone on the ultrasound monitor, up and down movements of the table is not required. Now, what is required is the lateral movements of the table to get the stone onto the focus. Now, here is an example, midpole calculus. Patient is lying supine, the isocentric arm head end marker towards the head end of the table. Now the patient is being lowered down. So as we lower the patient, we get to see this. Now we can see the stone here, but the marker focus point is here. Now once we see the stone, I will not change the height of the table. Now what I need to change the table, that is move the table in a horizontal way. So what I do here is, I have to get the stone onto the focus. So I will move the table away from the shockwave head. This movement will get the stone in the same line with the focus point. This is the one. Now the stone is here, but the focus is here. Now what I should do is, again I will not change the table height, I will move the table towards the leg end. So once I do that, the stone is in focus. Now we can start the treatment. Now the same thing, very important, as I told you, once I see the stone onto the ultrasound scan, I will not change the height of the table. All it is required to move the table in a horizontal plane. Now I move the table away from the shockwave head to get this picture. Once the stone is here, I move the table towards the leg end to get this picture. Now this description may look difficult and confusing, but believe me, once you start the treatment, it hardly requires any patient's cases to understand how to focus the stone. Now, once we start the treatment, the initial 100 shocks should be given at the lowest intensity. Then gradually we'll ramp the intensity to max at about 600 to 800 shocks. Now, the shockwave intensity should be kept as least as possible, which is required to fragment the stone, which is generally based on the stone HU. Usually, intensity between 1.0 to 2.5 should be sufficient to fragment kidney stones. Frequency should be at 60 per minute, and again the total number of shockwaves should be as less as possible to fragment the stone, or max 3000 per session. Now here is a short clip of a kidney stone, 2 centimeter kidney stone. The stone is getting fragmented. Few fragments are moving around, and you can see the fragments moving to the midpole calyx. That's the patient. This patient had 2 centimeter pelvic stone with few lower calyceal stones. The entire stone got cleared in pre-sitting. 2 for the pelvic stone and 1 for the calyceal stones. Now, when to stop the treatment? When you see that there is increase in overall bulk of the stone. This is the bulk of the stone before treatment and after treatment. When you see the clouding effect, with each wave hitting the stone, you can see the clouding effect. Movement of the fragments to the other calyx. The pelvic stone, after treatment, few fragments in the pelvis and in the upper pole calyx. And loss of posterior acoustic shadowing. You can see a nice posterior acoustic shadowing here, whereas when there is a fragments, you don't find them. Now, we have observed that there is a different kind of wave pattern when we start the treatment and when we are about to end the treatment when a stone is fragmented. This is a kind of wave pattern at the beginning and when the stone is fragmented. However, this finding requires further validation. Now, the question, ultrasound guided vestibular for kidney stones, is it more difficult or is a long learning curve? The answer is no. About 5 to 10 cases are sufficient for one to learn how to focus the stone. Now, coming to upper ureteric stones, the patient position will be supine. Prone position is required only for those stones which are closer to the iliac vessels. And this position, that is prone position, is not required for those lithotripters which has the facility to take the shockwave head above the table. Shockwave head position should be either lateral or on the table. Usually, most of the ureteric stones can be focused with these acoustic windows. These 2 acoustic windows in lateral position, this window in 0 degree position. And make sure that when you place the probe, again the head end marker should be always pointing towards the head end of the patient. Short video about upper ureteric stone. Patient is being lowered down. As soon as I lower the patient down, I see the dilated renal calyces, but I was unable to get onto the pelvis and the pugae because of the bowel gas. So what it is, sorry. So what I did is I changed the therapy, that is a shockwave head position from 45 degrees to 0 degrees. Now the shockwave head is in 0 degree. So when I did that, this is a picture what I got. I can clearly see the pelvis, pugae and the ureter. The stone is somewhere here. Now once I see this, again I will not change the height of the table. The height of the table is fixed now. All I have to do is move the table towards the head end. So when I start doing that, the stone will come into the focal point. This is a stone in the focal point, approximately, which is around 7.5 centimeters distal to the pugae, and you start the treatment. Stone, iliac vessels. Now, how to focus the stone? As I told, first go to the dilated renal pelvis, then to the pugae and to the ureter, and trace the ureter till you get the stone. Now, when we are doing so, when you are tracing the ureter down to the stone, again the ureter may disappear from the ultrasound monitor. At that time, we have to adjust the height again to get the ureter back and move the table cranially to get the stone onto the focus. So stones in the ureter up to 8 to 10 centimeters from the PUJ can be focused and treated. If there is no hydronephrosis, it may be difficult to focus the stone. In that case, twinkling effect or movement with respiration can help us to focus the stone. So there is one example, this is echogenic focus, which we thought it is a stone, but it was not moving with respiration. So when we refocused it, there is a stone which is moving clearly with the respiration. So the number of shock waves required per sitting should be around 1500 to 3000. Intensity again should be as least as possible to break the stone. Usually around 1.5 to 3 should be sufficient. Frequency should be at 60 shocks per minute. Some small clip of the ESWL to the upper ureteric stone. Stone is getting fragmented. You can see multiple fragments. Clouding effect. Stone further fragmented. Here we can stop the treatment. Now, how to assess the fragmentation? Sometimes this clouding effect increasing, looking at the fragmentation may not be very clearly evident. At that time, there are some indirect evidences which can tell us that the stone is fragmented. One is increase in length of the stone. Multiple fragments. Again, the clouding effect. Clouding effect will not be seen as frequently as we see with kidney stones. The change in color Doppler wave pattern will also help us to identify that. Now again the same question, it is more difficult or is a long learning curve? Again the answer is no. A little bit of more cases compared to the kidney stones are required for one to focus the upper ureteric stones. Now coming to the lower ureteric and VUJ stones, here the patient selection is very important. I prefer to select young patients. The stone should not be very hard. It's ideal for soft stones or moderately hard stones. And it is not recommended for female patient in reproductive age group because of the injury to the ovarian tissue. And it is difficult to focus the stone in a patient who has an excess belly fat. Patient positioning, the patient should be positioned in lateral position. This is a ipsilateral lateral position, that is, this position is for left ureteric stone. The patient should be tilted 30 degrees towards the shockwave head. Shockwave head position should be lateral and it is tilted 45 degrees towards the head end to avoid the pelvic bone. Now these are the acoustic windows where we can focus the ureteric stones. This window on the right side is used to focus the left ureteric stone. On the left side used to focus the right ureteric stone. Calculus in the distal ureter up to 4 to 5 cm proximal to the VUJ can be focused and fragmented. And again, if there is no hydronephrosis, it is difficult to focus the stone. In that case, twinkling effect can be helpful. Patient in lateral position, 30 degree tilted towards the shockwave head. Shockwave head tilted laterally. Get the patient closer and move the table down. So once I move the table down, I am adjusting the height. Once I move the table down, I'll get this picture. So that's the dilated ureter, the stone is here. So at this moment, again, I will not change the height of the table. What is required is to get the stone here by moving the table cranially. So I'm moving the table towards the head end. By doing so, the stone moves towards the focus point. Again, note that when I am doing so, I lost the ureter. So this is a point where again I have to adjust the height of the table. So once I start doing that, you can see the stone coming into picture again. Now there's the stone and this is the focus. Now the focus is here, stone is here. So what I should do is I should move the patient closer to the shockwave head. So once I start doing that, the stone will come into the focus. We start the treatment. Please note, there are two, So once I start the treatment, yeah, this is one type of wave pattern what we get when we are doing ESWL for lower Urethric stones, and another one is this. So there is a importance behind this, which I will be discussing in the next slide. So once we start the treatment, this is the final position. Yeah. So this is one kind of wave pattern which we get. Whenever we get this kind of wave pattern, we should be careful whether the wave is hitting the stone or not. It generally happens when the patient is lateral and it is not tilted towards the shockwave head. You can see here the bone is coming in between the waves and the stone. So once we tilt the patient laterally, the bone goes away and the waves will hit the stone properly, and this is the wave pattern what we get. Suppose if we don't confirm this, we feel that the waves are hitting the stone, but actually not. The treatment will be failure. So this is one short-lived lower Urethric stone, winkling effect, Uretric jets, starting the treatment, stones are getting fragmented, confirm, 2 fragments, couple of fragments, and the stone is almost fragmented. It's the same thing with the VUJ stone, the same patient position, the same shockwave head position, and the same transverse position. All is what is required is we have to smooth the patient slightly still towards the head end of the table. The number of shockwaves per sitting should be maximum 2000. Intensity will be less here compared to the kidney and uretric stones. It is around 1.5. Frequency, if you note, it is 90 per minute. Now why 90? Because this lateral position is not very comfortable for the patient. So we should try to finish the treatment as early as possible in the less time. About 20% of the patient will experience mild testicular pain during the treatment. About 2% of the patient experience hematospermia, which generally resolves on its own, and majority of the patient pass these fragments within a span of around week to 10 days. Again, the same question, is it more difficult or is a long learning curve? Answer is no, but yes, generally it requires slightly more cases compared to the kidney and upper Uretric stone for one to understand how to focus the stone. So to conclude, ultrasound guided ESWL has a short learning curve. It offers many advantages over fluoroscopy, and when it is integrated with fluoroscopy, definitely the results are much superior, and stones in most part of the ureter can be focused and treated with good success rates. Thank you.
Thanks, Professor Rajeev. Nice presentation. I have one question for you. Sometimes, actually, ultrasound guidance shockwave is good option. But you know, I usually make a puncture ultrasound guidance. Sometimes, for infection stone, ultrasound image is not clear. When you meet this situation, how to manage it? Sometimes not too much. For infection stone, sometimes you cannot clear under ultrasound guidance.
The infections has to be treated before we start the treatment.
I think he might be asking, Dr. Rajeev, infection stones may be difficult to see with ultrasound.
Okay, like that. Yes, maybe. Yeah. It may be difficult, yes.
You made it seem so easy, Rajeev. It seems like, why isn't everyone doing this? Plus, you can monitor the entire time,
Exactly.
and then there's no radiation. I must admit, when we got our Lithotripter several years ago, we tried the ultrasound option, but we thought it was too hard, so we didn't get it. So I think for the next one we look at, we should definitely do that. But you know, you will have no problems with breakwave, and in fact, it's actually even easier because with the breakwave, the energy comes from the diagnostic probe. So wherever you're looking is where the energy goes. So outstanding talk. Thank you. It was great instruction.
Thank you.
Professor Tiley, any question do you have? Tiley.
I just wanted to know from Rajeev why he is preferring the lateral position of the therapy head when treating kidney stones and not the posterior position.
So I am more comfortable with this position, and since my lithotripter has the facility to take the therapy head only in either 0 degrees or 45 degrees. It doesn't have a facility to take the table or the table facility.
So it's actually a matter of personal preference.
Yeah, maybe yes, sir. I am more comfortable with lateral position. Yes.
Okay, good. Okay, thank you.
Okay, thank you, Professor, your very nice presentation. I will move to the next speaker, Professor Zark. I will talk about management of stone in the children with Shockwave. It's the most effective modality in the majority of the cases. Please, Professor.
Is it all right now?
Yeah, right. Okay.
Do you see my slides, dear friends?
I can see it very clear.
All right. All right. Hello, dear friends, dear Chairman, Kowe, and dear Gerd, and distinguished speakers. First of all, on behalf of IAU, I am so thankful to you, all expert speakers focusing on the latest developments of shockwave lithotripsy. It's a pleasure to see you among us during our third webinar, and also we are so thankful for all participants today to our webinar to get the all latest information about the management of stones with shockwave lithotripsy, both in adults and children. Coming to children, over the next 20 minutes, I will try to focus on the use of shockwave lithotripsy in kids. We know that pediatric urolithiasis is a multifactorial disease, and the problem is high recurrence rates with high morbidity when compared with adults. And when we evaluate the underlying pathophysiology of stone formation in kids, here you see around 50% of the cases, kids will have a metabolic abnormality. And that's the most important factor to let them have recurrent stone formation during their life. And when it comes to the management of the stones, we have some problems or concerns to keep in mind. First of all, we need to think about the possible adverse effects of high energy shock waves on the growing kidney. Also, the other procedures need to be taken into account. Significant recurrence rates may require several procedures, and all these procedures need to be as less invasive as possible for the growing kidney of the child. Commonly underlying metabolic disorders is a problem, and also we need a cooperation between the departments, involved departments, and also parents are co-patients in these cases. We know it very well. Aims of the management is similar to the adults. We need a complete stone clearance with minimal or no complication in these cases. That means we need to be least invasive in these cases. We need to eradicate urinary infection, and also, if there is any, we need to correct the underlying metabolic or anatomic abnormalities to prevent recurrences. And to get the desired effect in terms of treatment, we need to combine the most effective and the least minimal invasive surgical method, and then appropriate prophylactic regimen need to be combined. We have these options as minimal invasive or non-invasive management options, but we know that shockwave lithotripsy is the only one which is really non-invasive, particularly in these cases. It has been introduced in the 1980s, you know it very well, but the first experience came from the children in 1986. And so far, you know that FDA did not approve this management modality in kids. Success rates and also complication rates are really acceptable in these particular patients. There are some advantages of the kids when it comes to the shockwave lithotripsy, because we know that children pass the stone fragments well and effectively, and they do not require routine standing in the majority of the cases. IV sedation may allow treatment in select older cases. That's possible now. Newer generation lithotripters with smaller focal zones allow less painful shockwave lithotripsy with limited adverse effects. And also, we know we may have better stone fragmentation rates for stone-free rates in these cases. We know that the stone formation period is shorter in kids. That's an advantage. And also due to the smaller body habitus, lower resistance of the stone to binary shockwaves is possible. Lower absorption of binary shockwaves by child's tissues is a reality. Ureter is shorter and more compliant when compared with adults, and children are mobilized earlier and effectively when compared with adult population. Stone size is very important, like in adults, and here you see for stones sizing less than 1 centimeter, around 100% stone-free rate could be anticipated, at least in some serious published data. Here you see. Also in large stones sizing larger than 2 centimeter, here you see around 67% stone-free rates has been reported in some published studies. High stone burden and multiple stones will lower the stone-free rates in a meaningful manner, also in kids like in adults. We know it very well. Also, at very younger ages, shockwave lithotripsy could be applied in caution in order to render them stone-free. Here you see the age of the patients here, and they are really very young, and the stone-free rates that has been published and reported are high and acceptable. That's a nice study summarizing the success rate of high-energy shockwave application in kids. The overall success rates range between 70 to 100%. Even monotherapy in large stones may give us really higher stone-free rates, as you see here. We may treat second calculi, lower pole calculi, and also stones in lower birth infants could be treated with acceptable stone-free rates and also limited complications. We know lower calcium calculi is a headache for adults, for us, in terms of treatment and getting a stone-free status. But studies, including ours, as you see here, did show that in children, treating the lower calcium stone with high-energy shock waves could give us really acceptable and higher stone-free rates when compared with adults. After a single session, here you see the stone-free rate was 28% in adults. It was around 67% in kids. And overall stone-free rates, here you see, really acceptable, and that means shockwave lithotripsy could be more effective with higher stone-free rates for lower pole stones in kids. And also some other studies show this reality. In this study, coworkers from Turkey, they were able to show that shockwave lithotripsy was equally effective for stones in all locations, including lower pole, and it is recommended as a primary treatment of choice for stone sizing less than 2 centimeters in all calcium locations. In this nice study, again, the authors did evaluate the efficacy and safety of shockwave lithotripsy for upper ureteric stones in different locations in children. Here you see the age of the children and a total of around 200 renal stones. In the end, they were able to show that the overall stone-free rate was 96%. And when it comes to the calcium position for lower pole stones, here you see it was around 72%. really high, really acceptable, and it is comparable with other locations. This is a study from our group, and we were able to show again that obesity, unlike in adult cases, might not be a disadvantage for shockwave lithotripsy in children for a successful outcome. We had two group of cases, children. In one group, obese kids were treated, and in the other group, normal kids with normal body weight were treated. And in the end, we were able to show that obesity was not a serious risk factor for kids in order to get a desired successful outcome when compared with the kids with normal body weight. Child's age, does it affect stone free rate after the treatments? Again, a study from our group, and we evaluated younger children with relatively older ones, and in the end, we were able to show that younger children were really more suitable in terms of to get higher stone free rates when compared with relatively older children, and also mean number of sessions were really limited in younger children when compared to older ones. In this nice study again from Turkey, our friends evaluated stone free rates after a single session of shockwave lithotripsy. It was related with auxiliary procedures. You see here the success rates regarding the for stones size is less than 1 centimeter, around 93%, and for larger stones it was around 82%. And children were found to be capable of transporting the fragments well and effectively after shockwave lithotripsy, and they concluded that interventional procedures should be a last resort. Watchful waiting for the spontaneous passage of the fragments is highly meaningful in these cases. In also one of our studies, we were able to show that in kids aging more than 10 years, here you see, we can use ketamine midazolam combination as an effective and safe choice for an outpatient anesthesia in these cases for a safe treatment. And the majority of the cases did tolerate the shockwave lithotripsy with this approach in a successful and safe manner. In this nice study, Dr. Sly, he evaluated current and future concepts of surgical management of stones in kids with an emphasis of shockwave lithotripsy, and he concluded that shockwave lithotripsy remains an important treatment option for kidney stones sizing less than 2 centimeters. Modern endoscopic treatment options together with shockwave lithotripsy allow personalized management of stone disease in the pediatric population. Let's go to the literature and evaluate the place of impact of high energy shockwave application compared to the other modalities in recent studies. Here in this study, here we may easily see that the authors did compare the shockwave lithotripsy between children and adults. And in the end, they were able to show that shockwave lithotripsy is more effective in children when compared with adults. Complications were comparable, and stone clearance rate, here you see, in general, were higher in kids when compared with adults. And ancillary procedures were less needed. That's a nice systematic review and meta-analysis coming from China, and our friends, they were able to evaluate 14 studies, around 1,842 cases, and sorry for that. And they were able to show that the complications were all minor in nature, and stone free rates, particularly for stone sizing less than 10 millimeters, was significantly higher when compared with the larger one. And shockwave lithotripsy was found to be highly efficient with negligible complications as the first treatment option in kids. Very clear message. In this study, the authors did evaluate the efficacy of shockwave lithotripsy compared with RIRS for stone sizing less than 2 centimeters in kids. And here you see number of active procedural sessions and number of anesthesia sessions was higher in RIRS group. procedure time and anesthesia time were higher in the Shockwave lithotripsy group, and they concluded that both have similar success rates. The more minimally invasive Shockwave lithotripsy should be chosen for pediatric upper urinary stones sizing less than 2 centimeters. Very recently published study. Let's go to the guidelines, pediatric guidelines, and see what guidelines say to us on this aspect. And here you see again, for pelvic stone sizing less than 1 centimeter, Shockwave lithotripsy in the first place. Even for moderate sized stones, Shockwave lithotripsy will be preferred in these cases. For lower pole stones and for upper ureteric stones, Shockwave lithotripsy is in the first place with a acceptable level of evidence. And ideal stone is sizing less than 1 centimeter. How about complications? Nice study reviewing the possible complications. Total number of the studies evaluated were 20, and the others in the end did show that the most common cause of complications was the size of the stone, and majority of the complications were really in minor nature, including transient hematuria in the first place. So, here again, complications were evaluated in a huge number of cases. 12% complications were noted with minor complications in the majority of the cases. We have some safety concerns in terms of radiation exposure, effect of the high energy shock waves on the growing kidney, and also alterations in the possible alteration in the renal growth. And when we evaluate the literature, that's a study that I was involved years and years ago while I was working in Salzburg in 1990. And we used HM3 in kids. That was a real chance for us. And even with use of HM3 under general anesthesia, we did not see any impact of high energy shock waves in the renal function of the kids, and also growth percentiles of the treated and non-treated kidneys of the children exposing to high energy shock waves. Also, the other studies did not show any long-term effects of high energy shock waves. Here you see a nice evaluation of the published data on the function and morphology of the kidneys, and Shockwave lithotripsy has been found to be safe and effective and non-invasive treatment option in kids. How can we maximize the efficacy of high energy shock waves in kids? We may use sonography. My dear friend Rajeev did talk about it in an excellent manner. That's the way. Let's use sonography to treat the kidney and also monitorize actively during the procedure. Anesthesia is an advantage for us to immobilize the patient and to have the stone just in the focus in the majority of the time. The number of energy of shock waves can be reduced, and stage approach could be applied. Low pulse setting and fever shock waves could be applied. In the end, we may conclude that technological advances in the stone management techniques have had a significant effect on the treatment of stones in children, allowing a safe and successful outcome. However, unlike in adult cases, minimal or non-invasive techniques should be used to treat calculi in children because of the greater probability of stone recurrence due to the commonly associated metabolic and, to a certain extent, anatomical problems. Due to the small body habitus, delicate tissues, and possible long-term complications, proper and detailed planning of the surgical procedure is highly important. Currently, there is a strong consensus on Shockwave lithotripsy as the initial treatment of choice for the vast majority of stones, including both kidney as well as the upper ureteric stones. However, there are certain definite indications of endoscopic interventions in this specific population, depending on the stone as well as patient-related factors. Thank you very much for your kind attention.
Okay, thank you, Professor Kemal. Very nice, excellent presentation. I have one question for you. Sometimes, pediatric little stone have some cystine stone. You see, for this stone, Shockwave is okay?
Very nice question. Thank you so much. that's a really different types of stones that we need to deal with. We know that it's coming from just birth, and it's a lifelong problem, needs lifelong treatment. And the answer for your question is, cystine stones are not, let's say, very well suitable for high energy shockwave application, because due to their structure, they are not disintegrated well, and for that reason, if the kid has particularly a large cystine stone, it may be wise to perform PNL in order to render him stone-free in a session.
But sometimes with small size cystine stone, you can use shockwave? No?
Yes, exactly. We can try our chance for stone sizing less than 1 centimeter. For example, let's think that the kid has a 5 or 6 millimeter calcium stone. It's a cystine stone, we know. We may try 1 or 2 sessions. There is nothing to lose. If we are successful, then it will be acceptable. But otherwise, then we will turn into PNL, if needed.
Okay, thank you. Professor Taddy?
So now we can proceed to the last speaker. This is Professor Su, facilitating spontaneous passage of the fragments after ESWL, and what are the practical measures to be applied and advised. Professor Su.
Okay. Because now time in China is evening, so good evening every professors. Today my topic is about facilitation of spontaneous passage of the fragments after SWL. What are the practical measures to be applied and advised? As we all know, more than 40 years after introduction into clinical practice, SWL has been considered the first-line treatment for the smaller kidney stone. Why? SWL can be the first-line modality for urinary stone because SWL has many advantages indeed. 1, it's the least invasive modality. 2, no anesthesia effort required. 3, it can achieve the high stone flow rate.
Hello? 听不到，没声音了，没声音了。Maybe internet problem. Doesn't work well, maybe.
I have a question for Dr. Sarika about pediatrics while we're waiting. You know, we do the shockwave for kids as well too, and I agree. We shock cystine stones too. I know that the textbooks say you should not shock cystine stones, but we do, and it works. So most of the time. And my question is, do you give any alpha blockers to the children after shockwave lithotripsy?
There's been a very nice question, and there are really very highly limited studies concerning the use of alpha blockers in kids. 2 of them did come from my country, and for 1 of them I was involved. And if the kid has residual fragments in the ureter that needs to be passed in a certain period of time, we give them, but not routinely, not in all cases, and we treat them really in an individualized manner, selectively. As I told you, if it's a large stone, and if we see the stone fragments in the ureter, then we give them, they tolerate well, and our study did show that if in selected cases, it's really effective.
Mm-hmm. Mm-hmm. And what type of imaging do you use afterwards for following the children?
Sonography in the first place, and if we need to learn about final stone-free status, if there is any suspicion, or if it needs to be defined for some other reasons, after 3 months, we may apply a CT imaging once again. But throughout the follow-up period, KUB and mostly sonography is the preferred imaging modalities.
Dr. Sarika, can I ask you a question?
Please, of course, pleasure.
Yeah, I am Dr. Joseph Philip Raj from India. Now,
Please,
what is the longest follow-up of your patients after ESWL in pediatric age group? Is there any discrepancy in the renal growth pattern or GFR?
Very nice question. And as I stated during my presentation, years ago, we used HM3. We know that HM3 was the hero for us, and I got the chance to work with HM3 in 1990 in Austria, Salzburg, while I was working there. Not only in adults, they applied shockwave lithotripsy with HM3 in kids also. And we followed them more than a year for HM3, and there was no adverse effect of high energy shock waves coming from HM3, very powerful, we know, in kids in terms of renal function, in terms of renal growth, and also body growth percentiles. But when it comes to other type of lithotripters, I have a group followed more than 3 years. And in these kids also, we didn't see any impact of high energy shock waves if applied really cautiously in terms of number of sessions, in terms of energy level, in terms of number of high energy shock waves. We did not see any notable effect of high energy shock waves in shock function and morphology of the kidney.
Thank you. Now the second question, you said there is no difference in obese and non-obese children regarding the effect of ESWL. Now, my question is, what is the distance from the stone to the shock head? Is there any difference in obese and non-obese individuals?
Of course there is, but that's not as pronounced as in adults. When we take the smaller body habitus in kids, obesity will not mean a huge fat, let's say, tissue around body that will really hinder the effect of high energy shock waves. The difference between obese and non-obese kids in terms of fatty tissue around the body was not really so remarkable when compared with adults. We evaluated data coming from adult cases also, evaluating obese and non-obese patients. There was a huge difference in terms of the distance, but when it comes to kids, obesity does not mean a huge fatty tissue in these particular cases. For that reason, there was no effect of fatty tissue in obese kids in order to render or hinder the efficacy of high energy shock waves.
I would have a comment on that. I think that the reason why in obese and non-obese children the results are comparable is that whether they are obese or non-obese, their skin to stone distance is still smaller or shorter than the treatment depth of any lithotripter. And I think that's the reason why obese adults have problem, because their skin to stone distance is longer than the treatment depth of the lithotripter. So in children, you don't have that problem, I think.
Exactly, yeah. Thank you so much. Exactly. That was the focal point.
If I am permitted, can I ask you one more question?
Please.
Now, what is the definition of clinically insignificant residual fragments in case of pediatric age group, especially following ESWL?
Very nice question and no definite reply, no definite answer. that's that's not fully defined in adults up to now. There are varying size of stones for clinically insignificant fragment. For some, in some studies you may find less than 5, less than 4, less than 3 millimeters. But in kids, such a definition up to now I haven't read in any publication. No definition up to now I've seen in any publication. That's why I will not be able to tell something or make any comment. Ben, could you tell something?
I'm shaking my head with exactly what you're saying. we don't know what it is.
I'm sorry, my internet is not good. And is it okay?
Okay, we continue Dr. Shu's presentation.
Please. Okay, I'm sorry. Okay, I'm going to continue. Next, I would like to talk about is China. And in 2008, we started to develop the machine by ourselves. And this machine was approved by Chinese FDA in 2012. And this machine in China is the first machine which can help urinary stone is pulsing activity. This machine is internal physical vibration recyclable machine. So this is the two picture is the first generation and the second generation and the third generation machine. And for the second generation, the robotic arms have replaced the manual operation of the first generation. And for the third generation machine was more intelligent. And the basic principle of this machine is multidimensional physical harmonic vibration inertial guidance technology. And this machine have two vibrators. The one vibrator is under the bed, is the pedestal vibrator. And the main vibrator is the hand-controlled vibrator. And in the second generation machine, and the robotic arms replace the hand control. And this is the basic principle. And the pedestal vibrator can generate a horizontal harmonic wave and can separate the stone from the cavity and can make the stone free. And the hand-controlled vibrator can generate the horizontal harmonic wave and push the stone wave and combine with the tail of the bed and to help the stone is discharged. And next, I will introduce how does the machine works by an animation.
The external physical vibration recyclable EPVL machine is composed of a treatment cup, an oscillate, and a main oscillate. The couch can be tilted forward and backward with up to 30 degrees. It also has both left and right side tilted with up to 15 degrees. The sub-oscillate located on the treatment couch could generate harmonic vibration wave in a horizontal direction that induce the stone fragments to separate from the kidney or ureter and broaden a moving space for the fragments. The main oscillate, which could rotate 316 degrees, could generate multi-directional harmonic vibration wave that provide an axial effect for pushing the stone fragments out. Now we introduce the Prevail technique in a case with renal stone located in a lower pelvis. The patient is placed in the supine position, and the couch is modified to a head-down tilt of 25 to 30 degrees. That will ease lower pressure stone fragments discharge. Then the sub-oscillate is used to induce the fragments to separate from kidney and broaden a moving space for the fragments. During the procedure, ultrasound could be used to monitor the stone location and guide the tilt angle of the treatment couch to assist the stone fragments discharge. After adjusting direction, the main oscillator is applied over the ipsilateral renal calyces with pressure to push the fragments to the renal pelvis. Next, we tilt the supine patient from the head low, feet high position to the head high, feet low position, and turn the body 15 degrees towards the healthy side. After adjusting the direction of the nail slit towards the ureter, the stone fragments are progressively discharged from the urinary collecting system.
Okay, let us to see the actual operation picture. And one doctor are treating a patient with the first generation EPVL machine. And after the EPVL treatment, let the patient to urinate, and we can see the fragments of the stone can discharge immediately. And this is the first paper about EPVL machine, was published in Chinese Journal of Urology in 2013. And this is a single center controlled, prospective controlled machine. And it have a conclusion, and the EPVL machine can significantly promote the stone after XW. Compared with the traditional method, EPVL therapy have a better curative effect. So, to evaluate the efficacy of the safety of this machine, under the leadership of Professor Zhang Chunye and Professor Guohua Zheng, and in China, we have conducted 2 prospective multi-center randomized controlled study on this machine. And one study is to study the effectiveness of EPVL in residual stone after RIS, and the second study is to study the effectiveness of EPVL compared with SWL. And for these studies, 8 hospitals from the different provinces in China involved. And the first study results was published in GEO in 2017. And the second study result was published in WGO in 2017. And in this study, and it have a conclusion, and we can see EPVL is a non-invasive, effective, and self-adjunctive treatment, which increased and accelerate upper urinary stone discharge after ESW treatment. And so, meanwhile, other professors in China have also conducted research on this machine and came to the same conclusions. And this study was conducted by Shanghai hospitals, and it have a result. The stone-free rate was 76% in the treatment group, but in the control group, the stone-free rate only have 48%. And this study was in the Jiangsu province in China, and it's for the 1 millimeter to 2 millimeter the Urethric stones. So, and it have same conclusions, and the EPVL and SWL are ideal partners in the treatment of upper uretary stones, and it can satisfy both high stone free rate and low complications. So, in Chinese Journal of Urology in 2017, and Professor Si Xingyang and Professor Zhang Chunye have a paper published, and they have write the innovation of upper urinary tract stone treatment from passive to activity. In this paper, it writes the external physical vibration reception system has gradually attracted the urologist's attention in recent years. This system develops a simple harmonic to drive the stone explosive, and this new conception has active reception. So in China now, EPVL has become a routine and effective means to assist stone removal after SWL in China. And now, more than 500 hospitals are equipped with EPVL machines in China. So, in the end, I have a brief summary. How can we get rid of the residual fragments after SWL? And EPVL and SWL is ideal partners. Thank you very much. Professor Zhou?
Okay, very nice presentation, Professor Xu. Because not too much time left, and now, any question for Dr. Xu? Come on, please.
No question. There is no question, but really congratulations. I'm so happy to see that because, you know, we always talked about the reality that shockwave lithotripsy is not effective, is not good. Shockwave lithotripsy is effective. In the majority of cases, we know that if the aim is to disintegrate the stone, it does. It is effective, but when it comes to pass these fragments, then the problem begins. For that reason, shockwave lithotripsy was effective, but with this new system, it will be more and more effective with the spontaneous passage stones. Thank you so much.
Really nice comments. Benjo?
Can I ask a question? Hello? Can I ask a question?
Yeah, please go ahead, Joseph.
Okay. Now, at least something good is coming from Wuhan. It's nice to know. The thing is there any randomized control trial done with and without vibrators regarding passage of stones and time for passage spontaneously? That's number one. What is the size of the fragments which are, you know, it has to be less than the ureteral size to be passed out. But does it help in passage of little bigger, like 7 to 8 millimeter stone because of the vibration?
就他问你，第二个问题就是这个 fragmentation 要多大才能用你这个 machine？ 你多大？
什么多大？
他问你，他说你这个 fragmentation 就是个碎片要多大才能用你这个机器去排出来？这第二个问，第一个问没有。
And we recommend the fragments less than the 6 millimeter can use this machine to this exposure. Yeah. Less than the 6 millimeter.
Okay. Any randomized control trials with and without vibrators?
做了，你做 RCT 做了 ，RCT 做了，我们做过 RCT 的啊。
We have the RCT studies, and these studies results have published in WGU in 2017.
Okay, thanks, Professor Xu. Because time is limited, is only 3 minutes left. Please, Professor Tally, have a summary for this webinar, please. Professor Tally.
Thank you all faculty. I think we had the most instructive evening, which will allow us, I think, to perform ESWL better in the future. We learned also about future machines on the burst wave, which may be interesting in the future. Also interesting is that ultrasound-guided ESWL is really a big issue. I think more ultrasound should be used in doing ESWL. I think many urologists are afraid to start with it, but it's really not that difficult. Also, I think that pediatric patients profit from ESWL, and there among urologists sometimes there's some trepidation to use ESWL in kids. I think that ESWL is the first choice for stone treatment in pediatric patients. Also, I was a bit impressed by the guidelines talk. I think the NICE guidelines are interesting, and I hope they will be used more often in the future. So I thank everyone for his contribution, and wish you a nice evening or morning or afternoon, wherever you may be.
Okay, lastly, good news for everybody. So far, how many people attended this webinar? 2,400. It's a big number. I think it's a good number.
Amazing. Amazing.
2,000. Okay. Bye-bye. Thank you. Thank you.
Bye.
Bye.
Thank you.
Keep safe.
Bye-bye.
Keep safe. Okay.
Thank you, friends.
Thank you.
Thanks a
Thank you,
lot.
friends.
See
Thank
you
you,
soon.
friends. Thank you,
Thank
Benjo.
you.
Thank you, Tally. Thank you,
Thank you,
Cable.
Dr.
Thank
Zhang. It
you,
was a real honor.
Alice, Pingus, Louis, Jiang.
Thank you
Professor Xu. Thank you. Thank you.
Wonderful.
Okay. See you.
Thank you. Wonderful service.
See you. See you.
See you. Thank you.
Good night to everybody in China. Good night.
Bye.